Conor, it's been a great few days. I mean, everybody's really rejuvenated, lots of stuff going on. Surprisingly, one of the topics that we spoke about today was care of the elderly and injuries within the elderly community population. Can you tell us a bit about that?
Yeah, well, I guess the first thing to say is that it shouldn't be a surprise to us that we're talking about the elderly, because right now we're experiencing a real growth in the activity levels and the numbers of people that are reaching 65 and older. And I was talking on the Spirit of Kinsale yesterday, and one of the stats that we presented, that was in 2011, we had something like 140,000 who were over the age of 80, and by 2046 that is going to be about 500,000. So our numbers of older people is climbing dramatically. So really our EMS services have to be able to cope with that, and it's going to it particularly is relevant in the context of trauma, because older people suffer trauma in a different way to younger people. What we've seen from NOCA's work in Ireland, NOCA is the National Office for Clinical Audit, and what we've seen from that is that major trauma in Ireland, that's trauma with an injury severity score of greater than 15, 40% of that is happening in over 65-year-olds. So we've got, and most of it is falls from less than 2 metres. So the most common mechanism of injury across age groups in Ireland is falls from less than 2 metres, okay? And 40% of that is happening in people over the age of 65. So what that means is that that traditional model of trauma that we all have in our heads, of a road traffic accident, a big smash on the fast roads where a car rolls and so on, and it's a young person, okay, that's actually less the trauma burden, if you like, than the older person who falls over, knocks their head, sustains a fractured distal radius, maybe a few rib fractures, and lo and behold, they've got an injury severity score that's much greater than some of the really dramatic road traffic collisions that you see.
So in your day-to-day practice currently, you're obviously working in the emergency department, that age group, that profile of patient, what type of injuries are you seeing coming in from this fall of less than 2 metres?
Okay, so that's a great question, Glenn, and I think one of the problems that can happen is you need to have a threshold of suspicion for the various injuries that can occur. So taking it from the start in terms of cervical spine, for example, we use all these rule-out rules for cervical spine injury, Nexus rule-out rule, Canadian C-spine rule, okay? And they all involve pressing on the cervical spine architecture, checking for neurological abnormality, making sure that the patient doesn't have alcohol or sedatives on board, and then seeing if they can move their neck, okay? What we don't realise often when we use these rules is that these rules were brought together on patients under the age of 65. They were validated for patients under the age of 65. Now we can extrapolate them to the older age group, but we need to do so with care. They're not as reliable in that age group. So for example, an older person can have a central cord injury when they hyperextend their neck after a fall. Mm-hmm. And that will present with relatively strong neurological function in the legs, but very weak in the arms. Okay, so that's one that we can sometimes miss. So it's having a high threshold of suspicion for injury. The other one that's a problem is the rib fractures. So I can fall off my bicycle and break 3 ribs. Okay, it'll be sore. I'll go on analgesia. I'll be warned that if I have any signs of chest infection, to take an antibiotic, go visit my GP, and take plenty of pain relief and use an incentive spirometer to try and get my breathing going well. Okay, that's me, 41. Yeah. Okay. If that happens to an 80-year-old, they come in, they have 3 rib fractures, okay? The rib fractures cause an underlying lung contusion, okay? That older patient doesn't have the same immune system as hopefully I have, and they go home 3 days later and they're in the horrors from a pneumonia, okay? They can't take deep breaths in and out, okay? Yeah. The medications that we use to try and kill the pain for rib fractures, like non-steroidal anti-inflammatories, the older kidneys don't like them, okay? Yeah. The older people's renal function can suffer with those, and they end up they get gastritis more readily, so they end up not taking the pain relief, and next thing you know, these guys are in respiratory failure with a lung contusion and pneumonia and desperate pain, okay? So really the effects of rib fractures don't manifest until 2 or 3 days later, and so we need to have a threshold when it comes to managing these patients, that these aren't like the young fit rugby player or footballer who get a rib fractures. These are older, and their likelihood of getting fractures then is also increased because they've got osteoporotic bones.
Yeah.
So their bones are like chalk.
Yeah.
And so, we often don't see their rib fractures on chest X-rays, but we know when we press on their chest wall that they're there because they're in extreme pain when you press on them. But then, of course, the elderly are very stoic. They're unbelievably stoic. I mean, you could have an elderly person with an unbelievable fracture where a young guy would be screaming the place down and the older person is just grinning and bearing it. And oftentimes they will say that they don't need pain relief when in fact they do.
And they don't want to bother you.
They don't want to bother you.
Didn't want to bother your son on this.
Yeah.
Earlier on when you gave your presentation on the boat yesterday, you talked about splat, the mnemonic splat. Can you give us some kind of insight into how you use that and what it does actually explain?
Okay, thanks, Glenn. So splat refers to the assessment of falls, okay? And what can often be difficult in responding to a patient who has had a fall is knowing what caused the fall, okay? So did the patient trip over a carpet, over a lead, okay? Was it just a simple trip? Or did they have a collapse episode, okay, that caused them to fall? So did they have an arrhythmia that caused them to collapse and fall over and break their hip and be sitting there with their foot externally rotated and shortened, and you're going, okay, they've got a neck of femur fracture, but you don't realise that something catastrophic has happened that caused them to fall over in the first instance. So splat is a mnemonic that's suggested. And it stands for S is symptoms. What symptoms did the patient have before the fall happened? Okay. P is for previous falls, because some people are predisposed to falling. Okay. They may be issued with hip protectors. Okay. They may have had the full workup already for falls, and there's a workup that's done in the hospital setting and in the general practice setting for people who fall. So P is for previous falls. L is for the location of the fall, because if that person was outside all night, okay, having fallen outside, then they're going to be hypothermic. If they were stuck in the same spot for a length of time, okay, there's a chance that they might have rhabdomyolysis because there was muscle breakdown, and of course that rhabdomyolysis can cause kidney injury, and so we need to look out for that as well. So that's SPL. A is for activity. What were they doing when this happened? Okay. Were they peeing, for example? Okay, because there's such thing as micturition syncope, where somebody goes to the loo and has a collapse and then breaks their hip or puts their hand out to save themselves and fractures their distal radius. Or did they suddenly get up from sitting to standing? Okay, so the elderly patients are often on beta blockers. They're often on antihypertensives like thiazide diuretics. So their heart doesn't have the same responsiveness in terms of circulating blood around the brain when they suddenly go from sitting to standing. Okay, and so they're also dry then. Okay, so their tank is empty, okay, because of the diuretics, okay. So they wake up in the morning to go out to the loo, or they wake up in the middle of the night to go out to the loo. They suddenly want to go out there, they suddenly get up and splat, they're on the ground, okay. So that's A, what were they doing? Activity, what was going on. The other thing to record is the time of the fall, okay, because again, if they were laying there for a length of time, they're going to, suffer consequences of that, be that hypothermia or pressure areas, okay. So pressure areas on the skin if they were lying there for a length of time, and then we mentioned rhabdo already. And then the final thing is T, okay, what trauma have they now sustained, okay. So you get all this information before you ever go and entertain the trauma element of it, in terms of the fractured neck of femur or the fractured distal radius.
Very interesting, very interesting. Splat. So yesterday, what was your key message you wanted your group to take away from the boat when they left you yesterday? What was the key thing you wanted them to remember?
I think the key thing is that there is now, in terms of major trauma, there are now two types of major trauma. There's high velocity major trauma, which we see mostly in young people who roll their cars or come off their motorcycles or come off their racing bicycles at high speeds. And then there's lower velocity trauma. And the lower velocity trauma are those falls that happen from less than 2 meters. And the elderly are very frequently those that sustain that type of injury, okay? And we need to have a skill set for managing trauma in the elderly that's different to managing trauma in younger people. They have a different range and complexity of illnesses that makes managing their trauma in the first instance more difficult, but their response to traumatic injury is also different, okay? They don't have the same resilience as a younger person might have. So we need to predict that, and my key message is be generous with your pain relief in the elderly. Okay, they're stoic. It doesn't mean give them lots of morphine. It means give them morphine, but give them half the dose that you would have given to a fit, muscular man, okay, or woman. Okay, and a fragile old person, you need to half that dose, but do give that dose. What I often see is people are clung to the bed in pain. Okay, they don't want to disturb the nurse to go to the toilet, okay, because they don't want to interfere with people, and so they develop pressure sores because they're in so much pain because they haven't had enough analgesia. Okay, so be generous with the analgesia, titrating it carefully, appropriate to their what they can tolerate, but be generous with it nonetheless.
Brilliant. Feedback yesterday from guys getting off the boat was excellent. Another great talk, another great session. Conor, thanks very much for giving us your time.
Thanks, Glenn.